Welcome to the COVID-19 series, NYU Wagner Alumni in Action. My name is Gordon Campbell, and I'm a professor of practice at NYU Wagner. The genesis for this series is to highlight NYU Wagner alums who are on the front line responding to COVID-19. Tonight's focus is the healthcare response to COVID-19, and I'm pleased to be joined by four distinguished alumni from NYU Wagner. The format for the webinar is a conversation with each of the panelists, followed by a group conversation, and then we turn to you, the audience, for questions. And by the way, if you want to ask a question, just click on the Q&A icon at the bottom of your screen, and you can type in a question. So before we begin, let's look at the statistics. The CDC statistics as of today, September 24th. Globally, 31,746,600 cases, 936,800 global deaths. US cases, 6,874,982. US deaths, 200,275. And right here in New York City, the number of New York City cases, 241,858. And New York City deaths, 23,782. These are indeed alarming statistics. And even more important are the individuals, the families, and the communities behind each of these numbers. Let's begin with our first panelist, Israel Roca, who's the CEO of NYC Health and Hospitals Elmhurst. NYC Health and Hospital Elmhurst serves an area of approximately 1 million people. Elmhurst, Queens is perhaps the most ethnically diverse community in the world, with 20,000 recent immigrants from 112 different countries. Elmhurst's patient population is primarily from South and Central America, Asia, the Caribbean, and Eastern Europe. Israel, welcome. Located in the most diverse community in the world that speaks over 180 languages, you have talked about being the epicenter of the pandemic. What were some unique challenges in a community like yours with so many marginalized groups? Israel?
Welcome, everybody. Welcome this afternoon. It's a pleasure to be with you. I think that at Elmhurst Hospital, we always have some challenges that we face when we're trying to help our patients understand the conditions before them, whether they be language barrier, access, healthcare literacy, or different types of issues that we encounter in our special population. I think that during COVID, there really was a lot of information that we needed to share with our patients. There was so much information that was flowing from so many resources that I think normally I would say that the language barrier is the first challenge, but this time around, I think it was language and literacy. I think there were so many statements that were being made and so many different sources of information that people didn't know who to turn to find out what was true. Should I stay home? Should I come to the hospital? Should I get tested? What's the appropriate test? When should I come to the hospital? When should I be alarmed about COVID? What are the correct symptoms? How can it be spread? And then even that, when we had to change our care operations considerably, where patients could not have their family members visit them, and we had to create different types of structures and settings to let that happen. I think there was so much that happened in COVID so quickly. And really, when I say, I think the whole country at some point has been an epicenter. I think the real challenge has been that we were first in that series of epicenters that happened. And I think that we went through a lot of challenges, learning, discovering, and innovating treatment protocols, and then having to educate people about the illness simultaneously. And I think those were some very special events that our team helped to rise to the occasion to provide for our patients.
Israel, it's really interesting when you're talking about usually or typically it's the language challenge, but this time was language and literature, how everyone was faced with the whole challenge about family members and loved ones wanting to visit those that were in hospital settings. And you're right about the epicenter. At one point was Elmhurst, but it's literally moved around the country and for that matter, the world. So Israel, Elmhurst had the first open access testing in the country, a sophisticated outdoor ER triage system, which I saw on television numerous times, and increased the bed capacity of your intensive care unit by 500%. How were you, your staff, and others able to achieve this?
You know, I have to really give credit to the amazing care team that Elmhurst is blessed to have work and serve our community. I think they kept innovating. And the real goal that we had at Elmhurst Hospital was that prior to what we had seen here in the United States, we saw that some hospitals internationally had difficulty. Some of them couldn't continue to service their communities. Some of them had to create new alternatives of providing care because they couldn't welcome everyone in and care for them. Our main mission at Elmhurst Hospital when we met with the team was that we are not going to turn anyone away, and we are going to provide care for everyone that needs care. And we were going to be there for them no matter what. And we would figure out ways to get that to happen. And so every day, myself and members of the team from every level of leadership to every level of care, we would meet multiple times throughout the day to figure out what we needed to do today, what we needed to do tomorrow, and where the statistics were telling us we needed to be a week from now. And we were simultaneously, each broke up into teams to solve each one of those problems. We had a team for today, a team for tomorrow, and a team a week from now, working simultaneously with our central office partners and other hospitals within New York City Health and Hospitals to render those cares. And those innovations happened, and we worked very quickly to do them. So whether it was open access testing, which you're correct, was the first in the country, those lines that people saw outside were patients who needed care, that Elmhurst was providing care, who came to Elmhurst because we were the only ones that were doing that type of testing first and foremost. But I think the team was always finding ways. So whether it was that testing, whether it was starting protocols faster, whether it was reaching out to pharmaceutical companies, or whether it was creating innovations and providing care, we had teams always figuring out what we needed to do to change our operations, dismantle them, and make them work in a way that kept patients safe and provided care on a timely basis. And we're proud to say that throughout that entire experience, the Elmhurst care team found a way to innovate, provide care, and never turned a single patient away that needed assistance, and were able to give them the assistance that they needed to be able to bring them to stability and give them every fighting opportunity to survive COVID.
So, Israel, I really like the fact that you and your team at Elmhurst really started with the premise, we're not going to turn everyone away, everyone will be treated. And the notion of keep innovating on a continual basis, really adaptive leadership, and then also on understanding that one person can't do it alone, and meeting collectively, meeting in groups, all about shared leadership. So, Israel, my last question for you, given the prevalence of COVID-19 in your community, do you foresee any type of herd immunity developing? And that's been a real focus of late.
You know, I think that's a complex question and no one really has the answer. And I wish that I could give you an answer. There are many theories, and you know, we have met internally with our infectious diseases team. We work with hospitals all around the world and we're monitoring. I think that there are many schools of thought. There are some ideas that, or some thought that once you've had COVID, you have immunity, and that's why we have the anti-serum tests that people are checking to see whether or not they have antibodies, and that those antibodies will be able to be triggered should you get re-exposed to a COVID condition and maybe give your body the ability to fight it better. And that was really where we worked to create the plasma therapy that really did help some patients. How long that immunity lasts, how it works, we don't know. The family the coronavirus comes from is very similar to the flu and others. And we see that every year we need a new flu shot because the flu continues to progress and change. And we've seen COVID mutate to many different forms as it's moved throughout the country. And I think that that's really what we're monitoring. The answer, truth of the matter is that we really don't know. It's too early on for us to determine whether or not a herd immunity could build. We hope that that would be the case and that someday we would be able to say we're all immune to COVID and this is behind us. However, we don't know. And I always tell people, when you're dealing with something you don't know, the advice I have gotten is err on the side of caution. So until we can absolutely prove that herd immunity is something that can develop, I would feel unsafe telling anyone that that's something they should rely on. But we will.
But thank you. And as Dr. Fauci said, in New York City, we're only at 22%, which we've got a long ways to go. So thanks, Israel. And now I'd like to turn to our next alum from NYU Wagner, John Sendek, who is the Executive Director of North Shore University Hospital. John is responsible for the day-to-day operations of the 800-bed advanced care hospital. North Shore Hospital is one of the cornerstones of Northwell, as well as an academic campus for the Zucker School of Medicine at Hofstra, Northwell. Welcome, John. So the first question, John, for you is, what was different, if anything, about the response from an academic teaching hospital? How did you balance the priorities of responding to the crisis versus teaching medical students and residents? John?
Thank you very much, Gordon, and I'm glad to be here with you. You know, the issue about academic medical centers versus non-academic medical centers is something that we thought a little bit about once we had a moment to sit back and think. And I have to be honest with you, in our health system, we obviously have a mix of teaching hospitals and non-teaching hospitals. I really think that this pandemic, in many ways, was kind of one of the great equalizers. I think we all suffered from a lot of the same problems. And really, I think that the challenges that we were faced with, which was battling an illness that people had no experience treating, a tremendous amount of fear in the community and a tremendous amount of fear in society, and a lot of misinformation. A time when even people who work at a place that are used to dealing with complex cases were themselves frightened for themselves and their families as staff members, recognizing that in other cases we say to ourselves, we may see difficult trauma cases, much like Elmhurst does. We may see difficult brain aneurysm cases. We may see sad cases of cancer that takes people's lives. But for the most part, the staff themselves is not nearly at risk as they are in the case of a pandemic, where disease transmission avenues, our inability to understand the degree to which PPE is working or not working, just threw all of us so many curveballs that if you were talking about it in a tabletop exercise, you would think that the people designing the exercise were just trying to trip you up. And in this case, it was actually really happening. I'm not sure that whether you're an academic medical center or a non-academic medical center, what you were trying to figure out was any different. And for us, what may have been a little bit different is that while we had this, group of doctors in training, these residents who are here and who may have to now pivot, much like all of our other physicians, those that work in ambulatory settings, those that work in, areas that were not as impacted, and be ready to pivot very quickly. For most medical centers, I think we experienced this too, you went from having a 20-bed medical ICU and hundreds of beds of other things to now having a hospital where literally 90% of the patients are medical ICU patients. And that's not what you're staffed for. That's not what you have all types of other services that you provide, and you have people who are doctors and nurses and residents and trainees, but everyone's got their subspecialties. And we're saying now to people, we're going to ask you to step out of that. And I think for us, it was about recognizing early on that this was going to be a game of attrition. We had heard from our colleagues in Italy who we had spoken to in February that you better get ready to very quickly start to see employees getting sick and not being able to come to work. And so we decided early on that our focus was going to be ready to move and transition to converting more of the hospital to medical critical care. But secondly, to start focusing hardcore on staff education and protective equipment for employees. Because we felt that if we started to not be able to keep enough employees at work, our job was just going to get much more difficult.
So John, I think it's really interesting about your point is a great equalizer no matter what the hospital in terms of its approach, in terms of its work, and also just really focusing on your staff. And speaking of which, how were you able to lead and manage your staff in responding to such an acceleration in patient volume? And also too, as you're talking about going into the void, the unknown, this was new for all of us.
Yeah, I think communicate. For our standpoint, the chief medical officer here and I, and the rest of our executive team, one, at work every day. We made a commitment that we were going to be present. We socially distanced. We kept apart. So if one of us got ill, we didn't all become ill, but we were at work. We felt it was incredibly important to be visible to the people who were working at this medical center on a daily basis, and we made sure that we did that. The second thing that was incredibly important was to stay 40 beds ahead every day. and communicate what the plan was. So we were getting information out every day to the staff of this institution, what was going to be the next unit that we were going to quickly start to convert to being a COVID positive unit. Because as the discharges of the, a hospital like North Shore is not dependent wholly on its emergency department for admissions. And so when about half the medical center is full of patients who arrived here electively previous to COVID, we're still trying to battle those scheduled procedures, the patients that are in the house who had procedures. And as those patients are starting to discharge out, that's making room for the arriving COVID patients. And then you get to the point, as many of us experienced, where the COVID patients that were here have been here now 2 weeks and they're not going anywhere. And we were burning through what we considered to be a net add of 40 patients, 40 beds a day was the gap between discharges and admissions. And so we were being very communicative to all the floors and to all the staff and to all the physicians at this hospital every couple of days what the plan was going to be. And we found that that was incredibly instructive in helping people understand that there was a plan. We were not going to allow there to be a perception we became overrun. And we did that by communicating so that people could do the best they could to push their fear aside. It was not easy, and stay focused on coming to work. And then, as I emphasized to you, we focused on showing our employees and the physicians and the staff here that we were 100% focused on them and their safety. And by doing so, we got them to feel comfortable that they just needed to continue to do the work that they did. And we were incredibly proud. And before the clapouts became a thing with fire departments showing up and the community, we were doing a lot of that type of stuff with our workforce, as I'm sure my colleagues at the other hospitals were doing, to applaud our staff early on. And one of the things I had said was, when the September 11th attacks happened, I was a relatively young EMS worker in New York City. And I remember thinking the cops and the firemen and EMS workers were the heroes of that. And I remember early on in the pandemic thinking, it may take a while, but the public's going to turn around and say that the healthcare workers are the heroes here. And it was nice to see that came to fruition. I think that boosted the morale of healthcare workers across the country.
Right. So John, communicate. And I really like the fact you said, stay 40 beds ahead, that it was real planful, which I'm sure was really reassuring to staff, and not only to applaud staff, but to support staff. Thanks, John. And now we're going to turn to Ebony Carrington, who's the CEO and COO of New York City Health and Hospitals Harlem. New York City Health and Hospitals Harlem is the largest hospital in central Harlem with 272 beds for acute care and services as a designated level 1 trauma center. At the age of 36 in 2016, Ebony became Harlem Hospital's youngest ever CEO, managing more than 2,400 employees and a $440 million budget. Welcome, Ebony. So first question for you. What does real-time leadership in action, which you talk about, mean? And did it always work? And what were the lessons learned going forward?
Thank you. First of all, thank you for having me, Gordon. For me, authenticity was really important during this pandemic, and to own some of the vulnerabilities that we were feeling and experiencing, and to really practice the empathy of what does this feel like? I'm not a clinician. So what does this feel like when you're asking some people to leave their families and really in some cases face uncertain peril? So what we really tried to do was ensure that we had very, very clear objectives. So I want to say that I felt uniquely qualified at this point because everything I had done in my career, in some ways, I feel set me up to be able to lead through the pandemic. So as an operations leader, we were ahead on the plexiglass. We were ahead on looking at the air management, the air quality of our organizations. We had a very, very clear surge plan. So leadership in action was pretty much taking that fear factor that you experience and the unknown of there's no best practice for this, and just really figuring out how you leverage your own individual strengths to be able to lead with confidence through this situation. So one of the things that we really worked on as an emergency management leader is that I ran the command center personally. So myself and my cabinet were sitting in the command center. We understood the PAR levels of our PPE. We were able to hear the specific concerns of the staff. And although I'm pretty risk averse, I took a chance to actually deviate from some of the goals of the healthcare system. And that, I think, is leadership in action. And so while the system was looking at liaising with multiple city agencies, helping to support some of my colleagues like Israel that were hit first and very early, we had to figure out how we were going to ready a very small staff that actually is struggling with choreography and coordination. So we prioritized limiting exposure. I sent a lot of people home that I didn't find to be required. It was less people crossing the threshold, pushing the elevator buttons, consuming PPE. And so we decided to limit exposure in that way by actually sending some folks home. And it was just the first day we knew that this was going to hit a fever pitch. We said, if you work in an office, stay home. If you are not a direct care provider, stay home, so that we could really focus on whoever was here and keeping them as safe as possible. And one of our other objectives in terms of leadership and action was making sure that psychological safety was preserved. And so talking to people about balance, speaking to them about their home plans, making sure that they understood that we wanted them at their best. And so this wasn't about working triples and doubles. And so we really wanted to make sure that we looked at our staffing levels, that we integrated the new allied professionals that came on and some of those from the military to ensure that people could preserve themselves. So I would say in terms of leadership in action, it was about really making sure that our goals were facility specific, although we are a part of a larger system. And so there was a bit of that risk to take in terms of the departure from what we were being told every day. There was the need to exercise servant leadership by being in that command center. There was so much that we learned from picking up the phone directly. And staff actually said, I can't believe I have you, so I'm gonna keep coming. If you're coming, I'm coming. And there were a few days when it got so bad that we didn't have any patient transporters. And indeed, for about 3 or 4 days, I served as a patient transport in the COVID unit so that people could know you don't have to wear an N95 right now if you're not, in the line of a directly aerosolizing procedure. And by doing that, one, they saw that there was this desire to be with them. There was a person who was in senior leadership who understood what it felt like to, dread the elevator door closing when you were in there with a COVID positive patient, really not knowing what that felt like. So servant leadership, emotional intelligence, and what I would really say is constant communication. We established a different email address that was called Harlem Required Reading. We asked people what they wanted to know, and every single day without fail, we gave them information that wasn't noise. It was short, it was bulleted, and it met their needs. And so we pulled them, and we made sure that we constantly aligned it back with some of those goals so that they understood that they were always a part of a very structured and comprehensive plan. And from the janitor to the neurosurgeon, it was that level of organization and presence that made them keep coming back. And when we talk a little bit later about culture, we'll be able to show how we could actually demonstrate the improvement in our organization through metrics as a result of this leadership style.
So Ebony, so what I hear from you is really practice empathy, understand that the hospital staff not only have issues being at the hospital, but in terms of their homes, their communities, with their families, clear objectives, and really walking the talk by running the command center. And then being willing to take risks that you've thought through, but knowing I don't know if they're actually going to work. I think all of that goes a long ways. So Ebony, the second question for you, you just reference it. What is it about the Harlem hospital culture? When you and I were talking about it, you said you put it in a bottle, Harlem 2.0, that works so well with both current staff as well as the influx of essential workers that joined you and your team.
So I want to be really honest and transparent in this moment. We are not overly sophisticated as an organization. Our ability to work as a team is something that we're struggling with. And so during the pandemic, because of the newness, and I would say because of the fear factor, we had an unprecedented level of compliance, of coordination, and of collegiality that when we saw it come together, it was like magic in a bottle. And so the way that we felt, the way that we organized, the way that we communicated as a team, our medical record was seamless because everyone was talking. They wanted to ensure that they were on the same page. And so through the pandemic, we were able to see something that we wouldn't in the past. There were no union grievances there. And I apologize, I'm very union supportive, but I'm just saying there were no obstacles. You know, the regulatory requirements were waived. You had the ability to innovate a little bit differently. The tradesmen came in and built things for you. And so what we saw was the ability, when all of the obstacles are out of the way, for us to really run a very superb hospital, one that I would receive care at myself. And so we called that Harlem 2.0. We call that desire to be a part of a team, Harlem 2.0. And now when there's any behavior that's contrary, we actually name it and we say that's not where we are in 2.0. What we've seen as a result of this is a different level of accountability at our mid-management level, where we are holding them very directly accountable for their department, because during the pandemic, they hunkered down and they were within it. And so we just continued to leverage that and move it forward. And the other thing that we've seen post-pandemic is an increase in our reportable incidents. And so as we work through metrics and around a culture of safety, you really want to see that people are open, sharing their errors or sharing things that aren't going right. And post-COVID, we've actually seen a 110% increase in our reportable incidents, not because we're providing lesser or different care, but because people are now more comfortable and more trusting in their leaders to share what's not working. And so I would say that our culture before was very family oriented, but not very coordinated, and a little bit difficult. And Harlem 2.0 really saw what good could look like. And we've been able to rally together around the same. And we saw that through the report out from the armed forces. When they left, they said, not only did we find this to be a very nice, supportive environment, but we think you guys got your stuff together. And so I was glad to have seen that. And then because you're always seeking performance improvement, we found that we had a lot of opportunity to improve our normal culture through having been pressure tested through the pandemic. So our decedent affairs could have been improved, our visitation management could have been improved, as well as our onboarding processes for our clinical providers. So through the pandemic, we saw that when stressed, there was some opportunity for improvement, and we've been able to really put some more consistent frameworks in place.
Great. So Harlem 2.0, compliance, coordination, and collegiality. Thanks, Ebony. And our last panelist, another NYU Wagner alum, is Brian Byrd. Brian is the Senior Program Officer at New York State Health Foundation. As Senior Program Officer, Brian manages the Special Projects Fund, a $3 million annual funding opportunity that takes on projects responding to the changing healthcare environment, especially the innovative ideas that emerges from the health field. Brian, welcome.
Hi, thank you.
Brian, how do you deal with the misinformation in your role, such as conflicting CDC guidelines, which is happening every few days of late, or drug makers not being forthcoming about vaccine trials?
Well, first, I just want to just sort of say thank you to Israel, Ebony, and John, because, you know, they're on the front lines. They have been doing all the hard work. I feel kind of humbled in the sense that we're not necessarily on the front lines. We sort of are very much behind the scenes. But with regard to misinformation, it's funny because we originally had started working on it when we had this uptick in the measles outbreak. And that was back in probably in like March of 2019. And we started working with the grantee public goods projects to address that issue. And we were dealing with misinformation around getting vaccinated for measles, your children, and things like that. And then when the pandemic hit, in a sense, we were very lucky. We already had a system, almost like a disease surveillance system in place that already knew how to address that and how to put it into context, and then also provide messaging and other strategies for health providers and journalists in addressing that. So it was, you know, it started out literally from the ground up. At the time before the pandemic hit, we had maybe 75 users of Project Vector. That's the name of it. It stands for Vaccine Communication Tracking and Response. And as of today, they now have more than 530 users of that, including, ironically, the CDC, members of the CDC. So it was very, very difficult. Luckily, we already had something in place, so we were able to easily pivot towards it. But misinformation is really, really, really bad, as you know, and it continues. And it doesn't help when you have various leaders who are creating it and promoting it and trying to address that. And then you have to try and figure out, well, just the fact that it's out there. As for instance, I was dealing with a politician who said, well, when in doubt, you know, take it out or don't use it. And that's all it takes. And as we're starting to get to the point where, you know, they're developing a COVID vaccine, we feel misinformation has to be addressed much more vigorously than it has been.
So I think it's really interesting, Brian, how you actually took the work you were doing and then you said you pivoted and you just didn't start from scratch. You really built upon it. And just following up on this question, given all this misinformation out there, what do you advise people in the audience like us? Who do we believe? And what do we believe?
What do we believe? Well, the first thing you have to do, I always say, and I was a victim of it back in 2016. There was a lot of things that were going on that really kind of upset me at the time. I mean, the first thing you do is you have to be suspicious of the source. And you have to sort of apply the brakes to yourself, especially if it's a very emotional message or image or things like that. Because a lot of times the people who are promoting misinformation know what they're doing and they know what buttons to push. And so what may seem like an innocent puppy or somebody who's doing something that initially sounds cute and they say, like this, a lot of times there's something else that's going on behind it. So the first thing you need to do is really just be suspicious and challenge and do your due diligence and check to see what the source is. Another thing is to do is where's it coming from? And this kind of ties into what I just said. You know, false accounting. There's a lot of fake social media accounts. As a matter of fact, you know, on social media, a lot of these misinformation is being promoted by bots. It's not actual human beings, but they're disguised as to be a human being. So you have to be aware of that. Sometimes it seems like it's coming from a real information source. Like for instance, the perfect one would be at ABC News Tonight, which is a fake Twitter account. Things like that. So you have to do that, and you have to do all of that before you start sharing it. Because that's the key thing with misinformation. The moment that you start sharing it, just because you're glancing at it, you need to double check your sources. You need to find out, go into other parts of the web, places that you trust, that you know has the real information or you feel has a better sense of information. You need to do that. And then if it's a question of whether or not it's vaccines or other things, you should really contact and talk to your healthcare provider. You know, usually they're the ones that will really know the information. I know that I talk to my primary care provider a lot of times just to run things past her, just to see what her take of it is. So those are, I would say, the top line things that you can do.
No, but Brian, it's very helpful. So in terms of information, be suspicious of the source, especially if it's emotional, pushing one's buttons, due diligence, where's it's coming from. And I thought that your last point is do all of this before sharing. So I want to thank each of the panelists. And if you in the audience have a question, make sure you click on the Q&A icon and just type in a question. And now I've got a question for each of the panelists. The question is, how have you seen firsthand the impacts of racial inequity and disparities in the pandemic? Black, Latino, and Native American populations 2 to 3 times more likely to test positive, up to 5 times more likely to be hospitalized, and up to 2 times more likely to die. 42% of all workers deemed essential are non-white, which includes 31% of all healthcare workers. And we all know there's underrepresentation in the vaccine trials, which are happening as we speak. So let's hear from Ebony, Brian, John, and Israel. Ebony.
Sure. I think several of the panelists are going to talk about health disparities. So what I'd like to talk about is the Harlem community and the minority community response to the pandemic by virtue of their support for research and clinical trials. I think that we focus as an organization and as a healthcare system on addressing chronic disease, which at the heart of the matter is what the base for COVID building on created. And so what I think the problem was here, we live in a food desert. We have food insecurity. We have people who have to make difficult choices between paying for co-pays and paying rent, or losing their job, or coming in for healthcare. And so I would say that we're very clear on the mission of health and hospitals as it relates to offsetting those disparities. What's exciting is that people have gotten past some of the fear factor they've had as it relates to research trials. And within our community, they were very, very open to talk about the remdesivir. They were talking about IL-6. We already had participated in some genomic research through the All of Us study. And so they were very, very ready and well positioned to talk through this. So I would say some of the impact has been that we want a seat at the table. The people of Harlem don't want to be left at the end of the vaccine trials. They don't want to be last to have the opportunity to preserve life. And so what I thought was beautiful about this was that the response actually pushed past the fear factor. And so where some people always want to look back, sometimes to Tuskegee, sometimes to Henrietta Lacks, we now are saying we would like to be a part of this. We want to know more so that we can be healthier. And we hope that that offsets some of the inequity and the disparities that I know some of my colleagues will talk through. But I thought that that was a way to start, kind of with a silver lining, that people have taken this as an opportunity to get past some wrongs of the past and to participate more fully in the health and wellness of minority communities as it relates to research and specifically some of these clinical trials.
Thanks, Ebony. Brian?
You know, it's interesting. One of the things that we've, you know, the way that we've realized this is that when the pandemic started to break, I spent probably the majority of my time speaking to all of our grantees who are on the front lines who are doing it. And the main question was, how is this impacting you? What are you seeing? How can we be helpful? Because the whole premise of what we were doing at the time back in March is, to quote Steve Jobs, is that we had to think different. The way that we used to in the pre-pandemic era, the way that as a foundation we used to operate and behave, we had to throw that out. And in many ways, we were kind of improvising how to be, as I was putting it earlier, sort of behind the scenes and being able to support those who are on the front lines who are really dealing with that kind of work. And additionally, so what we were getting back from our grantees and from other providers and frontline workers is a lot of this information that you were talking about. In fact, we were finding this out, and it was just kind of confirming what has already been the case before the pandemic. The one thing about the pandemic, and I think John and Ebony and Israel mentioned this, is that a lot of these issues were already there. And the pandemic, what it did was it just exacerbated it. And because folks were now sheltering in place, it just really was highlighted it so you couldn't ignore it or be distracted from it. And so from that point on, we tried to change or pivot our grant making strategy, to take all those factors into consideration.
Great. You're absolutely right about the racial inequity and disparities. We're definitely there before the pandemic, but in many ways just really bubbled to the surface. John?
Yeah, and I appreciate Brian's comments, and I think Ebony hit it right on the head. I think there's a silver lining here, which is that we feared that these pre-existing disparities would be made even clearer through something like this. We knew there would be disproportionate effects, I think, just understanding public health. And as I think everyone feared that, I think we saw the same representation of the way this illness and the worst case of this illness disproportionately affected certain populations. I think the silver lining is exactly what Ebony talked about, which is, we at this particular institution took the opportunity to say, let's get groups of people together and begin to talk about what we saw, because we thought that was helpful for staff. But also we have many folks who work at this medical center who are interested in being more involved in their community around driving awareness around community health and trying to further address some of these health disparities. And we have a pretty robust council of folks who've been meeting with me to share ideas on what more they think this particular hospital can do, because despite the fact that North Shore University Hospital is a very large academic medical center in size, certainly the largest on this side of the East River in Nassau, Suffolk, and Queens, it's ultimately a community hospital to its community as well. And so it shares that responsibility of understanding what are the immediate needs as it relates to health disparities around this hospital, and what discussions are we having internally to address it. In as much as Northwell Health, our parent organization, was very, very public about getting into certain communities throughout Brooklyn and Manhattan, getting involved with the churches and deploying all kinds of strategies to share correct information with the community, do testing and things of that sort. I think it was nice to see here that in the aftermath of this, and as it was beginning to wind down, among the first things that our staff raised their hand and said is, we got to be talking about what we just saw, and we need to figure out how to do more and put plans into place in the next 6 to 12 months to get out into the community more and talk about ways in which we can raise awareness and help folks manage their health in a way that perhaps we can chip away at something that, as I think Ebony noted, has unfortunately been there. And I think that I think we all feel good about what we can do with what we experienced, because we didn't read about it, we saw it. And I think there's a difference.
Thanks, John. Israel?
You know, I would say that when it came to looking at differences, whether based on socioeconomics or race, what we really worked to address at Elmhurst was trying to make sure that some of the things that we could do to help protect our patients and those who are in the community, a lot of the things that were being done to help individuals didn't work for individuals who had socioeconomic challenges, or who were day laborers, or who were blue collar workers. For instance, when a stay-at-home order was put into place, you said very early on in your statistic, essential jobs were critical and were needed to be done, and that is a larger percentage of individuals who are people who are from brown and black communities, and that meant that those individuals were not going to be protected by stay-at-home orders. Individuals who had to go to hotels, individuals who had a higher risk factor to the disease because they were working in hotels or in airlines or in areas where there were greater areas of individuals that were clustered, and even just the way that we live and the socioeconomics of the type of housing that you can have, and whether you can isolate, whether you have the ability to have 2 bathrooms and or not, and just have 1 bathroom for a whole household. How do you isolate in quarantine? So what we really did was to make sure that, 1, there was literature in every language that was available. That still was a challenge because there wasn't early on. Most literature was still being done in English, some Spanish, and not a lot in other languages, where we have one of the most diverse areas in the community originally. And I mean, not just print, but news, information, up-to-date information was really critical. But then also telling people how they could live and what they could do to still be able to provide for their family and take some precautions to protect themselves and others and those around them. And I think it really took an innovative approach to look at this, not like the historical socioeconomic challenges that we deal with from a lens of poverty and illness, but from a lens of practicality, and saying these people are still required to go to work because they're drivers, there are service individuals, and they will still need to go out there. They still will be exposed. What can we do to minimize that? So when they come back to their family, living in maybe a home that doesn't have as many resources as those that are more affluent, how can we still protect them? And how do we make this not a monolithic caution tale, but a real hands-on approach to addressing the patients that we see before them in terms of how they live and how they eat and how healthcare is real to them?
I'm really struck by the common themes from each of you. And then the last question for the 4 of you before we turn to the audience. As Wagner alums, how has that education experience shaped your response to the pandemic? As Wagner alums, how has that education experience shaped your response to the pandemic? We'll hear from John, Brian, Israel, and then Ebony. John.
You know, I've often said that one of the strongest elements of my NYU Wagner experience was leadership. I think that at the time I was looking for programs, that's what NYU and the Wagner program in particular, talked about, training and developing leaders in public service. And, if there was ever a test, I thought, again, back to some of Ebony's comments about how she thought she was uniquely positioned for this. I mean, I think that this is the test. I mean, I don't know. I mean, of any other situation I could imagine that challenges you in so many different ways, personally and professionally. As I said, in the earlier parts of my career, when I was a student at NYU, I was an EMS worker in New York City. I actually worked out of the Elmhurst area in the 4-6 battalion. And for me, I don't ever remember being frightened. I was frightened during this, and I had this enormous sense of responsibility for an enormous institution and the people who work here and the patients who are cared for here. And it's a role I had only stepped into in January. So, you know, less than 90 days in, you know, this is the kind of story. And so for me, I think feeling as though we accomplished some of the things we did and feeling as though we got through it the way that we did, I think what NYU gave me tremendously is leadership skills. And I think I continued to develop them over the years that followed after my graduation. That's certainly the part of the NYU education I feel most strongly about.
So John Wagner experienced leadership. Brian?
I think that you know, in many ways, John has kind of stole what I would have said, you know, leadership qualities. But one of the things that, and I say this all the time in the foundation about NYU Wagner students, that we know how to get things done. And that was the thing that I always used to say, you know, when I'm looking for an intern or, you know, when we're partnering, I can always tell when I'm working with somebody who's from Wagner, because they're not afraid to roll up their sleeves and get their hands dirty. And I think that because of that and having that sense of juggling things, because I was working full time as well as going to Wagner. And so the fact that I had to juggle a lot of different types of things involved all simultaneously, I think being able to do that and graduate from Wagner, I think definitely prepared me for something like this, because juggling a lot of different things, the uncertainty, not panicking, but still channeling that sense of urgency and I wouldn't say fear, but enough of that energy so that, you know, you had to get things done. And if anything, that was one of the things I've always carried with me from Wagner and all the positions I've had was get it done.
So Wagner, getting things done. Thanks, Brian. Israel?
You know, I would say that one of the things that really was a tribute to Wagner was the way that they really, you know, their curriculum brought you real life problems and how to solve them, whether it was the tools and how to lead complex operations, whether it was a lens at looking at how you can balance your financial performance, or even, you know, one of the classes I remember that just told you how to make sure that when you're solving problems that you're not addressing symptoms, but actually the underlying root cause of it. And I think that there were little pieces of all the coursework that I've taken at Wagner that I remember and that I found incredibly valuable that were very applicable during this time, because I think that you've heard a lot about the leadership, and I think a lot of programs can offer that, but I think Wagner was different in that it really does show you real life examples of what executives have done and give you a review of how those can be operationalized and put into practice. And I think that that was tremendously impactful during this time. And the way that Wagner does mix a mix of leadership and practical operations into their program. And I think that was a phenomenal asset that Wagner prepared me during this time to make sure that it wasn't just theory, but it was operations, theory, and finance together. And that was a benefit.
So Wagner, real life problems and how to solve them. Ebony?
So I've often felt like Wagner is kind of like stern with a conscience. So I would really say that it was humanity. I went to school for public service because I wanted to be able to look across different industries and to say, what does this look like for schools? What does this look like for transportation? And during the pandemic, I found myself to be a city leader. Yes, I had the task functionally of running a hospital and responding in that manner, but I wanted to know what was happening with the schools. I wanted to understand how people were getting to work. I wanted to appreciate what zip codes were, where the supermarkets were open. And so I feel that emotional intelligence was a cornerstone of my Wagner education. I continue to keep the books behind me. I do reference them because there are components of your course of study that are evergreen, and you have to be able to pull on them. And so when this pandemic hit, there's nothing else except there are going to be parts of me that I have to pull out. And it was making sure that people felt seen, people felt cared for, and people felt respected in this moment so they could come and see and feel and care for others. And we really didn't see any call outs for people that were not sick related to COVID. We saw people who said, can you move my schedule 30 minutes so that I can make sure I drop my child because I want to get to work, because I want to be there. And in some cases, I'll be candid, I'm a very we person, but some people said, I want to be there for you. And so I think Wagner just positioned me to be an effective leader, but a compassionate leader. And that's where I find that we have a little bit of competitive advantage, because we're bright, but we also, we have a heart as well.
Wagner, compassionate and effective leadership. So now I'm going to turn to my colleague, Tom Hernandez, who's the Director of Alumni and Student Engagement. And Tom, what are some questions from the audience?
Thank you so much, Gordon. And thank you to all of our alumni panelists for sharing your experience and your insights with us. And most of all, your very valuable time. We have a lot of great questions from the audience, and I want to actually start with the one that was a common theme through a couple of questions. So a lot of people are concerned and wondering how you are prepping for the merging of flu season and a potential second wave of COVID. And along with that, if there's anything that keeps you up at night.
So Israel and John, let's hear from you, just because I want to make sure we get through as many questions as possible. Israel?
Sure. So I think there's quite a bit of things that we're preparing for that are a little bit different. So the flu and I would say the combination of flu and COVID was what we believe really can lead to some of the most acute conditions. So we are preparing from tests, we're preparing the way that we structured our hospital, we've enhanced our emergency plans, and we're doing very robust education, treatment, starting flu clinics and testing. We also are looking at algorithms and looking at different parts of the world and looking at countries that activated before us to look at their trending. And so we are concerned with some of the patterns we're seeing from France and from Italy and from Spain that really were the precursors to what we saw here in New York, and really looking at the pathology and spread and their spikes, and then also looking at what happened flu season around the country. Usually what happened in the Southern Hemisphere is a predictor of what happened now. Fortunately, it was a very calm season because people are taking all the precautions. And I would say that we still have a lot of control by wearing masks, practicing hand hygiene, and that's what we can do. What keeps me up at night is one thing. When we saw COVID move, we saw it move in different regions, but no one area was activated simultaneously. And so we could rely on staffing to relieve our hospital when we had one area hit. So countries' resources were moved around. We could move people from Texas and California came to New York when we were needed. We went to other areas when they were needed. The concern that I would have is that it would all activate at one time. And so all the resources and supply and logistical challenges that we saw, that we confronted, would be that much larger when you look at the entire country having to respond to a spike at one time. We've not seen what kind of toll that would take on our system, and how we would not have those resources we had in the past to be able to move supplies around when the country's pandemic epicenter was moving around. And so my concern would be that, and just making sure that we have the ability to have the number of tests, treatment, and supplies that we need should we get all activated at one time, and the whole country is the epicenter of the epicenter.
So Israel, no plan for action keeps you up at night. John?
Yeah, and I mean, I think a lot of hospitals are looking at this the same way, so I won't belabor the points that Israel made, but suffice it to say North Shore 2 is got, you know, increased plans around emergency surveillance, disease surveillance. We've kept a number of our temporary areas ready to go in the event that we need to flip them. And even some of the temporary mobile hospitals and hospital tents that were stood up on this property have remained stood up and ready to go on this property. They weren't used the first time around, but they're available in the event, God forbid, we need it the second time around. I think what keeps me up at night has to do with fatigue. I think that, much like we're hearing about in society, if people are fatigued by all the restrictions and the disruptions to what they perceive to be their lives, and don't continue to be as diligent about hand washing and mask wearing, I worry about that alone causing some of the growth and pushing us into a situation where it'll be hard for us to manage continuing to take care of people who need care. Right? I think the worst thing we want to do, or the last thing any of us want to do, is get to where we have to shut our hospitals down to patients who don't have COVID and need care, and go back to kind of being forced to manage exclusively COVID patients. And I think having lived through that and seeing some of the ramifications to patients who were harmed by staying home, and I think all of us read about those stories, but some of us experienced those stories. I think we're going to try as hard as we can, if we can, if there's a spike up the next time around, to figure out how to manage that in a way that we can live in two worlds. And I think that will be incredibly difficult to do. So
John, keeps you up at night, fatigue, not only for you, but literally for all of us. Tom, the next question for Brian and Ebony.
Yep. What are the most impactful tweaks in care that your org has picked up since COVID started? And are there any policy changes that you think would help improve future care?
Great question. Brian.
Well, you know, it's funny. We kind of rely on folks like Ebony and Israel and John for that type of information, since we're not necessarily a provider of these services. But not, you know, the thing is that making sure that we know what is needed for the hospitals and for the, you know, the healthcare clinics and the folks who are actually providing these type of services is the thing that we really have to make sure that we stay on top of. I mean, we're setting aside funding in preparation for the second wave, probably in conjunction with the flu as well. We've released a brief recently, as of yesterday, about the flu vaccine and the flu season and things that folks can take in order to protect themselves. And as far as what keeps me up at night, I think when folks sort of let their guard down. I think you know, John mentioned that. I worry that we got a little bit over the summer, a little bit too complacent, you know, with the warm weather. You know, you see folks not wearing the mask. I'm sure folks are not necessarily washing their hands. And that keeps me up at night, fearing whether or not we're going to be ready for the second wave.
Great, thanks, Brian. Ebony?
Sure, just a few quick bullets. So one of them, in terms of our care delivery, is that we begin to take our OB patients directly onto the floor, as opposed to having them stop in the emergency department for any clearance, which is kind of a CMS requirement that they at least be assessed before going up to this care and treatment setting. And we found that for the moms, that experience has been fantastic. So we looked at different patient flows as a result of COVID in one way. We looked at bed management, and we have an algorithm that actually has proven very, very, very well correlated with the probability of a patient that is going to be COVID positive or negative in terms of rooming them with other people. So our bed management has been modified, our patient flow has been modified. And on the softer side, we wanted to make sure, again, that no one died alone during COVID. And so we created something called the Presence Project, where an individual ensured that they were standing, holding the hand of the person before they transition. We've been able to carry that forward as well. And it's been tremendous in terms of family support and the perception that people, including the person in the bed across from the individual who may, you know, be ultimately expired, that they've seen that. And so those are just a few of the things that we've made modifications from, and they've really been able to help care experience and employee engagement.
Thanks, and I wish we had time for more questions, because believe me, there are a lot more questions, but I want to thank each of our Wagner panelists for a thoughtful and robust discussion around such an unprecedented challenge that's impacting literally everyone around the globe. I have to tell you, you've made us proud, along with so many other NYU Wagner alums on the front line. Keep up the good work. We need you. And thanks to you, our audience. And please join us for our next webinar, COVID-19, the Social Services Response, which will again feature 4 Wagner alums on October 22nd at 5 p.m. Be on the lookout for a registration for an invitation. And until then, please continue to be safe and be well. Good evening.